result of doing 2 clinical trial classes for the last test, I had to push off a lecture on survival analysis. And so the way things are going to go for the last 2 classes, it was scheduled that we're going to do 2 classes on screening. And since you guys get screening covered in depth later in the curriculum, I'm going to do next class on survival analysis, and then the last class will be on screening. So that's just important for you guys to know. It's a slight difference from the syllabus. Another announcement that's not up here, the extra credit for the next exam is now posted. It's basically the same thing, very similar at least to the last extra credit assignment, in that you're asked to read a case control study and answer questions about potential sources of bias and the methods the researchers used to address those sources of bias and to interpret the results of the study. So that's on Blackboard now. That's it for announcements. Any questions? Any questions on the assignments or anything class related? The question is, what's the difference between a mediator and a confounding variable? So, the technical definition of a confounder, you probably have a sense of what a confounder is, right? It's a third variable that's accounting for the relationship between the independent variable and the dependent variable. Part of the technical definition of a confounder is that it's not located in the causal pathway between the independent and dependent variable. So, a mediator is located in the causal pathway between the independent variable and the dependent variable. So in the case of mediation, you have an independent variable, say it's treatment. And you have an outcome, say it's, lowering blood pressure. And your treatment actually does cause reduced blood pressure. But there's a third variable in the middle there. So treatment causes reduced stress, which causes low blood pressure. So it still causes lower blood pressure, but there's a variable that's in the middle. And it's part of the mechanism, it's part of the pathway linking the causal relationship between the dependent variable and between the independent variable and the dependent variable. Confounding variable is not in a causal pathway. It's basically creating what looks like a causal relationship between the independent variable and the dependent variable. But there is no causal relationship, or the relationship is actually weaker than it looks like because we didn't account for this third variable that's related to both the independent and dependent variable. So we'll talk about that a little bit more today. Any other questions? So I have something I want to talk about a little bit that I wasn't planning on in this lecture. And it's something that I noticed came up in the extra credit assignment. And it's something that we noticed came up in the handouts that you all just got. Who can tell me the difference between random sampling and randomization? Because there's a lot of confusion between the two. Specifically with thinking when I say randomization, I'm talking about random sampling. Yeah.
So in random sampling, every person in the population has an equal chance of getting selected to be part of the sample.
Okay, so I'll stop you there for 1 second. So random sampling has to do with pulling a sample out of a population. And like Michael said, it means that everybody in that underlying that big population has the exact same chance of making it into your sample. So you have a nice representative sample of the underlying population that you're interested in. So that's random sampling. It has to do with randomly selecting people from the population into your study sample. And then what about randomization? Yeah, so once we have our sample, then people are randomly assigned to treatment groups or experimental groups. So you can have a study that has both random sampling and random allocation. People are randomly picked from the population, and then they're randomly assigned to groups. Yeah, Cameron.
Can you say that?
Random sampling is selection. It's the process of selecting people from the population, but you're doing it randomly. Any questions on that? Because that's a really important distinction. So, yes, the actual assignment of people to groups can only happen after you've made a decision about whether or not they can be included in the study. Sometimes researchers create the order of randomization before people are selected. So we know the first person is going to go into the control group. We know the second person is going to go into the experimental group. So we pick the order ahead of time, but the actual assignment can't happen until you've made a decision about whether or not somebody should be included in your study. So selection happens before allocation. Sampling happens before assignment. The goal of random sampling is to create a sample that's representative of the underlying population. The goal of random allocation is to create groups that are essentially equal as possible on all variables except for your independent variable. So different goals in different stages of randomization, or using randomness. You want me to read that? So, what did I say? Random sampling has to do, the goal of random sampling is to have a sample that's as representative of the underlying population as possible. The goal of random sampling, the goal of random allocation, randomization, random assignment, however you want to say it, is to reduce allocation bias, is to reduce confounding bias, is to create groups that are as equal as possible. The ideal world is you have groups that are perfectly equal on everything except for treatment or whatever it is that those groups are, whatever the experimental condition is that you're interested in. Okay. Any other questions about that? What was the other thing that came up? Oh yeah. So there's some confusion in the handouts about the interpretation of odds ratios. I'm not going to get into that now, but we'll talk about that during review, for sure. So start off with your handouts. Think through this a little bit. Often the ultimate goal of research is to try to figure out if one variable causes another variable. Does treatment cause people to get better? Does a particular risk factor or exposure cause a particular disease or health outcome? And so, considering the potential for sources of bias from these different study designs, what I'd like you to do is think about which study designs have the greatest potential for establishing a causal relationship between the variables, and which are most susceptible to different types of bias. Yeah, there are. You have more tools. And sort of summarize what both Jeremy and Cameron said. The big one there is randomization. The big difference there is the ability to randomly assign people to the different groups. Prospective cohort study, people are either exposed or they're not exposed based on your measurement. There's no assignment to the exposure. And because we're not randomly assigning people to groups, there could be differences between those groups other than the independent variable or the exposure variable that's related to the outcome, which opens up the potential for confounding bias. So what do you have after prospective? So let me say this. So that's why it has less potential for establishing causation than randomized controlled trial. But why did you put it? Why is it second? Why is it towards the top of the list? What are some of the strengths of a prospective cohort study? Yeah, I'm with you.
So then there's like less of a recall bias compared to like retrospective cohort. See whether or not they directly observe they will have the outcome.
So I want you to throw out the word allocation because you're not assigning anybody to groups. But you're right. It's in real time. It's in real time. So we don't have issues of recall bias unless the exposure we're interested in happened in the past and we're asking people to remember it. But often we don't have these issues of recall bias or case control study potentially. And it happens in real time, which means we know the exposure is happening before the outcome. And in order for something to cause something else, it has to happen before that. The cause has to happen before the effect. So that's important. Temporality, we call it. So what do you have after prospective cohort? There's more potential for bias when you're looking at historical data because you're having to construct that data rather than collecting it in real time. So what about what's good about a retrospective study? Peter.
What's good about it?
What's good about it?
What's good about it is that you use like historical events, so like you can kind of like it's like it happened, so you can like look at it from today's point of view.
Why is that good?
It's good because you get a perspective.
It is good. It is good. Yeah, Michael, you want to add to that? It's cheaper. It can be cheaper, right, when you're looking at historical data. But sometimes what you're interested in happened in the past, right? I think this is what you're getting at, Peter. It happened in the past. Maybe you don't have the opportunity to explore it in real time. So there could be some research questions that aren't historical that you can only answer with historical data. That's kind of what you're doing, right? Yeah. Good point. Are the exposures always, what did you say? What do you mean by documentation?
So you look at past like documentation or records to see if they develop the problem. So then like is that the same to start off?
I'm not sure I understand. Is it always documented as opposed to like measured in real time?
Well, no,
So there could be circumstances where you're measuring the exposure that happened in the past based on asking people questions in the present, kind of like case control. So that could be a potential option. So there is potential for recall bias there. You can match in cohort studies too. It's just really common in case controls. It's usually cheaper to do a retrospective cohort study, and that's an advantage. It's the cost. Much less time too. You don't have to follow people 10, 15 years. Say it is an exposure like childhood something, and you want to know how it relates to, I don't know, something that happens later in adulthood. Prostate cancer. Right? That's a really long perspective cohort study. And people have done cohort studies that have lasted 30, 40, 50 years because you get really good data. But it's really expensive to do that. So if you have the ability to use data that's already there. So Cameron's question is, since with a retrospective cohort study, you're measuring everything in the past. At least with a case control study, you're measuring case status in the present. So doesn't that open up more potential for error? Yeah. I would actually say that this is kind of a trick question, but the difference between case control and exposure in terms of causation is kind of situational. It's kind of situational. It would depend on the study because they both involve the use of past data. And they both involve the use of previous data to sort of establish whether or not something happened temporally before the outcome. And then last but not least, cross-sectional studies. So, yeah, what about case control? Like, why is it better than? So we said, I was just saying that retrospective and case control are kind of comparable in their ability to establish causation. They're similar. They have similar limitations, similar sources of bias. One advantage of retrospective cohort study, if it's done well, is that we know the exposure happened before the outcome. So you have a little bit better of a chance of exploring temporality with retrospective cohorts, which is why you might put it above, but they're pretty comparable. So what are some advantages of case control studies in terms of causation?
I was gonna say in terms of causation over cross-sectional studies.
Yeah,
not the temporal association.
Yeah, you have a chance at getting at the temporal association between your exposure and your outcome. Because you're sampling people based on case stats, based on the outcome, and then you're looking back in time to see if they had the exposure. Now, if your cases are people who have had the outcome for some amount of time, and then you're recalling when the exposure happened, there is a chance that you could muddle things and that they actually became cases before they were exposed to whatever it is that you're interested in. But with cross-sectional studies, there's no chance at getting at that whatsoever because you're measuring both things happening in the present. And so you don't know which one came before the other, the exposure or the outcome. So for example, if you're interested in the relationship between post-traumatic stress disorder and alcohol dependence, and you have a sample of people, you measure their alcohol dependence, you measure their post-traumatic stress disorder, and you see how closely the two are related to each other. They're both characteristics of these people, of your sample, happening at the same time. So you can't say, if you find an association, that the alcohol dependence came before the post-traumatic stress disorder, or that the post-traumatic stress disorder came before the alcohol. So the point of this is to, start thinking about study designs in relation to each other. Pros, cons. Because that's going to help you put this all into a framework where you understand the different types of design. Second of all, it's important to understand the pros and cons of different types of study designs because it helps you be aware of what types of bias you might be looking out for. If you're conducting research, making decisions about what type of study design might be appropriate somewhere down the road, stuff's important to know. Okay. So here's a clicker question. So an investigator wants to study the association between a very rare genetic condition. No, but what you could do is you could ask mothers whether or not they are, mothers who are pregnant, whether or not they're smoking. Like a cohort study type of thing, where you're just observing whether or not that exposure is happening, and then following people over time to see if they evidence this rare genetic disorder. Alondra, yeah. Yeah, so I was just responding to Joseph's comment about morality, that you couldn't do this in a prospective cohort type of thing. You have another comment on that?
Yeah, but now that it should be covered, I said retrospective because
I didn't say it should be cohort. I was just responding to Joseph.
Well, I say it should be.
You say it should be cohort. Why do you say it should be cohort?
Because you can only observe social media different schools, and then I say it should be retrospective because it could take too long to study like others that are pregnant.
Okay. Yeah, I see your points, but why do you say that case control wouldn't just be observed?
In case control, aren't you supposed to like expose them to like this?
No, so case control is also observation. You're observing whether people are cases or controls. You're observing whether people have the outcome or not. And then you're observing whether or not they have the exposure or not. You're not assigning people to case or control. Pete.
I would love to answer Elijah's point because
You would what?
I would love to answer Elijah's point because I think that it's also retrospective cohort study because the question clearly asks which study design would be most feasible.
Mm-hmm.
And in a case control study, you have to follow them over time.
That's a prospective
That's a
cohort study.
prospective cohort. So, but either way, you have to follow them.
So a case control study, just a reminder, you're sampling people based on whether or not they have the outcome. So in this case, you would be sampling people based on whether or not they have the genetic disorder, and then you would be asking them whether or not, or you would be asking their mothers whether or not they smoked during pregnancy. So in terms of the amount of time it takes, it's pretty comparable often between a retrospective cohort and a case control.
Oh, well, can't you for a retrospective, you just find the result, right? And then babies who have the rare genetic condition, and wouldn't it be easier to discern?
So a retrospective cohort, in this case,
Yeah.
you would somehow use historical data to find women who were exposed, women who smoked during pregnancy. So in a retrospective cohort, you're still sampling based on the exposure, but you're using historical data to do it. And then you would be using historical data over time to see if those people develop this rare genetic disorder. And also you would still need to include a whole lot of people in your exposed versus unexposed to find people that have the outcome. So Aaron, you're correct that if it's very rare, you're going to have a hard time getting enough people. But think about the alternative in terms of the prospective cohort. You would have to have a huge sample of exposed and unexposed people to have enough chance to catch the people who got this rare genetic disorder. So at least when you're picking people, you can go out and try to find everybody in the world. There are studies that do this. You go out and try to find everybody in the world that has this genetic disorder. So you're getting as big of a sample as you possibly can. Whereas if you sample based on the exposure, you might not catch all those people with the outcome. You might have, 20,000 women who smoked during pregnancy and 20,000 women who didn't, and then none of their children have this very rare genetic disorder, and you just wasted, 5-10 years on this study and you have nothing to show for it. So the answer is case control. When it's a rare outcome, you can go out and you can pick people who have that outcome. So you can ensure that as best you can, you have enough sample, you have enough people with that outcome to actually have a meaningful analysis of the association between that outcome and the exposure. Any questions on that?
So that was rare exposure removed.
Okay, so I don't think I have a question about rare exposure. I just wanted to. So what do you think? If you have a rare exposure. Cohort generally speaking. Because you can then go and pick people who have the exposure and come up with a control group that doesn't have the exposure, the comparison. And then you ensure that you have enough people with the exposure in your study to then follow it over time and see if they, develop an outcome which is assuming is less rare. Did everybody catch that? The question was, what if you have a rare outcome? What if the example, or I'm sorry, what if you have a rare exposure? Any thoughts on that?
Using forward.
Why?
Because if you have a rare exposure and you group based on exposure, it's easier to establish. I mean, it's easier to get your sample first of all.
Yeah, it's the exact same principle as this. You're sampling based on the rare event. So that you try to ensure that you have enough people with that exposure in this case to have enough sample to conduct your study. So now this question is asked about budget, which we've talked about a little bit. Limited budget wants to study the association between exposure to natural disasters and the development of post-traumatic stress disorder, which is most feasible. Like today, I wanted to study this. Peter, you're right.
Limited budget.
Yeah,
Yeah.
the limited budget. So, retrospective, you're using historical data, you're not having to follow people over time. Another thing is if we wanted to talk about natural disasters, we would have to sit and wait for a natural disaster to happen. Which is a little weird ethically, right? Yeah. But you get the point, right? You have this, not that natural disasters are all that uncommon. There's usually a hurricane or in here, that kind of thing. But, yeah, in this case, for those reasons, budget, everything that Aphrodite said was spot on about it being a relatively rare exposure. And so we're talking about cohort study and then low budget, so retrospective. And so we don't have to sit and wait for a natural disaster to happen. Nice job. So this is a little bit of review. And so we'll go through this fairly quickly because it's review. Well, that's actually kind of extensive. How about for each of the types of study design, list 2 common sources of bias and the procedure used to reduce that type of bias. And do that in 7 minutes. No, yeah. No assumptions. You know what? We have a lot to get through, so let's go through this in real time. Let's talk through it. Let's do this prospectively. Okay, so first one, randomized controlled trial. Source of bias, Sarah. For selection bias, you use allocation concealment. Nice job. What about another one? You can reduce Hawthorne effect to an extent with blinding in some cases. Joseph.
Allocation bias.
Allocation bias, and that is addressed with randomization. Nice job. How about prospective cohort?
Is there allocation bias if it's already a randomized control trial?
Yeah. So there can be allocation bias, and that's why it's a randomized control trial. That's a procedure in a randomized control trial that's designed to reduce allocation bias. And you know that they're randomized because it's called the randomized control trial. How about prospective cohort study? It's classification bias. And what do you use to reduce?
Like you could get like a whole bunch of doctors, like if it's like a diagnosis or something, like you get 100
multiple opinions.
Yeah.
Yeah, the general principle is that you're trying to really carefully measure your exposure or your outcome so that you reduce the chance of actually misclassifying people. What's another one?
Confounding bias.
Mm-hmm.
Use statistical.
You use statistical adjustment in prospective cohort studies to reduce confounding bias. Nice job. Yeah, Karen.
I was gonna say lost to follow.
Loss to follow-up bias. What do we do to reduce it?
You can like give them like money if they do the same thing.
Give them incentives. Try and keep people in the study. Nice job. Retrospective cohort. A little bit trickier. We can repeat stuff. Recall bias. If our exposure is measured using recall or our outcome, and how would we limit that?
We could have like meticulous records, better keeping track of the records.
Not use recall, right? You could use records if at all possible. Nice job. Everybody.
Or you could also ask what the person knows.
Yeah, you could ask people around them, friends, family, to try and verify people's accounts of what happened. How about another source of bias? We'll do one more.
Or we could repeat stuff.
You can repeat stuff. Confounding bias. Yep. And what would you do in this case? Statistical adjustment. Now, this is an important point. I'm glad you brought this up. So, what's a limitation to using statistical adjustment to reduce confounding bias in a retrospective cohort study? And it's what you're going to say. Go ahead.
Well, in order to statistically adjust, you have to have the variable measured already.
Yes. And if you're relying on historical data, you're relying on records of what people have done in the past, having information on your potentially confounding variables, as opposed to prospective cohort study, where you're designing things as you go so you can measure whatever you want. So you're limited to what the data is available. That's actually a really important point related to what we were talking about before as far as advantages and disadvantages of study design for causation. I'm going to move on to the next one. Case control. Yeah? Oh, you have a question? Yeah.
I just, so for recall bias, how would you?
Recall bias in retrospective cohort studies, if at all possible, you can make your measures not based on recall. That's kind of obvious. Or you could use medical records, things like that. If you have to use recall, there's ways that you can try and make recall as accurate as possible. You can give people what are called timelines. So you walk them through different things that happened around the time period of whatever it is that you're interested in. It can kind of cue their memory. You could ask friends, relatives to verify accounts of what happened. Case control. Case control. Potential source of bias. Jessica.
There's recall bias.
Recall bias again, yeah. And see, careful measurement. Recall bias, doing everything you can to try and make recall as accurate as possible. How about another one? Nice job. Mm-hmm. Confounding bias, you match. Nice job, Eric. So remember, we can make groups equal on potentially confounding variables by matching cases to controls on age, gender, etc. What else can we do to reduce confounding bias in case control studies? I didn't mention this, so this is challenging you to think about it a little bit. I mean, we've already talked about. So that would reduce selection bias, which could in turn reduce confounding bias. I'm getting at something else. So how would that reduce confounding bias?
Oh, no, I would, sorry.
Oh, that would be a potential
Yeah,
source
yeah.
of bias. That would be misclassification, yeah. Having issues of where your temporality is mixed up. So in case control, yeah, so I,
But you also statistically.
yes, that's what I was going to do. Statistical adjustment. You can use if you've measured variables that are potentially confounding, just like cohort studies, you could statistically adjust in case control studies. There's no reason you wouldn't be able to do that. Cross-sectional study. Basically, every source of bias that we talked about for these other ones is an issue in cross-sectional studies. And when applicable, we use all the same stuff. We use statistical adjustment to reduce confounding bias. You use appropriate sampling as much as possible to reduce selection bias. Careful measurement to reduce misclassification bias, etc. Okay, nice job with that. So again, I'm just going to pose this question to you all. What are the differences between odds ratio and case control study and relative risk or rate ratio and cohort study? And
Is odds ratio it's the comparison between the odds that will happen and the odds that will happen between the two?
so that's one difference, right? In risk ratio or relative rate ratio or relative risk, you're comparing incidence, which is, in the terms of a rate ratio, it's a rate per 100 person years or whatever it is. Relative risk, it's a probability. It's a risk that something's going to happen. In an odds ratio, you're comparing odds. Probability of the event happening divided by the probability that it's not going to happen. So that's one difference. What's another really important difference? Yeah, Jared.
They kind of measure they now I guess they go in different orders.
Yeah, they do the opposites. So with relative risk and rate ratio, you're comparing the likelihood of the outcome between exposed and unexposed. With odds ratio, you're comparing the likelihood of the exposure between those with and without the outcome, between cases and controls. Yes. Relative risk, for example, you're comparing the likelihood that the outcome happens between the exposed and unexposed. Does that make sense? Case control, since we're selecting cases and controls based on whether or not the outcome that we're interested in is happening, we're then going back and comparing the likelihood that those groups had the exposure to each other. Not the likelihood, the odds that they had the exposure to each other. So relative risk, starting with exposed, unexposed, and comparing the likelihood of the outcome. Case control, starting with outcome versus no outcome, or case versus control, and comparing based on the odds that the exposure happened in the past. So if you set up your 2x2 table, you're going to be looking at different numbers there. So what's a similarity? They're both comparisons. They're both ratios. So the interpretation is similar. In that greater than 1 means a greater likelihood or odds, 0 to 1 means a lower likelihood or odds, and 1 means no difference in the likelihood or odds. Did you have something else? Lana, did you agree?
Yeah, I would say they both measure the association between exposure.
Yeah, they both measure the association between the exposure and the outcome that we're interested in. They just do it the opposite way. Okay, nice job with that. So now moving on to these new concepts. Confounding, mediation, and moderation. So what I'd like you to do is draw a diagram for each of the groups. So all of these involve 3 variables. All of them involve, for example, an independent variable, a dependent variable, and a third variable. The difference between them is how those 3 variables are related to each other. Who can draw a mediation? Swipe. Come on up.
That's funny.
Very nice. So can you describe what's up there?
So you have variable x that causes y, but there's another variable in between that x causes, which is responsible for y.
Very nice. Okay, how about moderation?
Between x and y.
Yes, very nice. Nice job. Any questions about that? So we have an independent variable, dependent variable, or exposure. Is that like a mic drop kind of thing? And so we have independent variable, dependent variable, exposure, outcome. We're interested in the association, the relationship between these variables. Now, the relationship between those variables might depend on who you're talking about. So if there's a third variable where the relationship between x and y depends on different levels of that third variable, that's moderation. For example, a treatment might be more or less effective for men versus women. Oh, Angela, do it first. Everybody looks at the so that's moderation. Any questions about that? Lydia. What's the question? Keep quiet, please. Yeah. Because there is actually a relationship between x and y. You know, confounding is where the most classic definition, there's not actually a relationship between your independent variable and dependent variable. But it looks like there is because there's this third variable that's related to both of them. Moderation, there is a relationship between x and y. It's just different for different people. No, not that. So I see what you're saying. You're saying there's like a different strength of relationship between the x variable and the mediator, and then the mediator and the outcome. And that would just be how you would describe this mediation relationship. You would say there's a weak relationship between x and the mediator, and then a strong relationship between the mediator and the outcome. So you're just kind of describing what that mediation is like. Now, what you could have is you could have a mediation relationship that's different between two different groups of people. So a treatment works better for women than men, and there's a mediator in between. That's called moderated mediation. But we don't need to talk about that. That's beyond this class. What's that?
So that's what I'm about to get into.
Oh, okay. All right. So, yeah. Where's my? Okay. So we're going to look at an example of moderation. This study looked at both moderators and mediators. We're going to look at moderation. Maybe mediation too. I don't remember. So this is a study where they're interested in treatment response for children with ADHD. And they're looking at moderators of treatment response. So what variables might relate to how well these children do when they take the medication. So this is kind of long. I'll summarize. They had some children with ADHD diagnosed 7 to 10 years. There's 3 active interventions. Did I say something funny? Medication management, behavioral treatment, and combined treatment. So we have 3 groups: medication, behavioral treatment, and a combination of the 2. That's a pretty common thing. And so then they're measuring impulsivity and hyperactivity. So this is the question regarding moderation. Does anxiety, these symptoms of anxiety, the extent to which the children with ADHD have these symptoms of anxiety, does that moderate the relationship between treatment And our outcome, our symptoms, hyperactivity and impulsivity. So we have this graph, and it's on your handout. And what I would like you to do is interpret this graph to your best ability in 3 minutes.
Are you looking for moderation or mediation?
Moderate. So the question was, does anxiety moderate the relationship?
Well, it says mediation.
Yeah, so that's where the difference is. It's the line for community care. And what it's really showing is a difference in the separation between the line for community care and behavioral treatment. So average score on the y-axis, that's the severity of symptoms. And then we have time along the x-axis, so the severity of symptoms over time. So for those with low anxiety, no anxiety, there's no difference in treatment outcome between community care and behavioral intervention, basically our control and behavioral intervention. But if you look at the children with high anxiety, those in community care have worse symptoms over time than those in behavioral treatment. So the efficacy, the effectiveness, I think in this case, this is a not blind, so I think we would go more with effectiveness here. So the effectiveness of treatment, behavioral treatment, depends on the anxiety level of the child. That's the take-home message. That's an important point because you might think this behavioral intervention works, and then you have a child with high anxiety. You might, if you put all these together, you might see a difference between the two. But then when you pull it apart by anxiety, you see this difference where the treatment doesn't really have an advantage over community care control for those with low anxiety. Yeah.
Dr. Smith, I just have a question.
Yeah.
When was this study
It was published in 1999, so it's an old one.
It's an old one. Okay.
Yes.
So with the stronger relationship, we
The anxiety group, right? There's separation between the lines for anxiety. So it has a benefit over community care for children with anxiety, but not children among children with ADHD without it. So quickly before we go, we defined an initial mediator as acceptance of treatment assignments and session attendance. So whether or not these people actually followed through with the intervention. And what they found was that attendance enhanced the treatment response. In other words, there was a mediation relationship where hold on a sec. This sounds like more like moderation to me. So treatment, I don't know what they're talking about. Treatment response was moderated by attendance. It worked better for people who showed up. So what would be an example really quick? Never mind. You guys can go.
Who has the attendance sheet?